Okay, Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back after the lunch break. And I will talk about the rule of how can we choose the biological therapy when we are treating rheumatoid arthritis patients. First of all, I would like to thank all of you for attending this lecture, and also to thank Roche for inviting me to talk on their behalf. Can we have the slides? What is the... Okay, so now, as all you know, whenever we are treating rheumatoid arthritis patients, for all of us as rheumatologists, we are looking to the different guidelines, either EULAR or ACR. And then when the patient needs biological therapy after failure of methotrexate, if you remember the guidelines, you could choose any one of available biological agents, either anti-TNF or IL-6, tocilizumab, rituximab, JAK inhibitors, or T-cell blockers, abatacept. And looking to these guidelines, we understand that there was no differences between the efficacy and safety for such patients. Even those who failed the first biological therapy, the recommendation will mention the same. So still in our mind, how can we judge the different biological demands? And how can we find the surrogate clear cutting edge between biological demands in our daily practice? And I think this is a very important unanswered questions for all of us. So I will try throughout my talk to highlight how could you choose the biological therapy when you face such indications. We all think about the efficacy. And of course, as a treating consultant, you wanted to give your patient an effective medication. But this again has to be safe. So if you have an effective medications which is not safe, you wouldn't prescribe it. So the medication has to be effective, has to be safe, and again has to be costly effectiveness. And this probably, it's important to us, but it's more important to the healthcare planners and purchase department. So now looking to this trial or study that's published recently, they compare the effectiveness of different biological agents in treatment of rheumatoid arthritis. They compare abatacept, rituximab, tocilizumab, and anti-TNF. And this study that's published from the real life data. So the objective of this study is again to evaluate the reality, the real life data about the different biological agents when they are indicated for treatment of rheumatoid arthritis. Because again, all of us think, what's the most effective or possible agent should I try when the patient has the indication to use the biological agents? So what they did, they reviewed the registry between 2010 to 2016, and they evaluated the patients who were given biological therapy, either as first agents, which was prescribed in more than 9,000 patients, or those who were switched after failure of anti-TNF, which almost near to 4,000. And they evaluated the effectiveness at 3 months and 12 months, and then, which is very important, the sustainability or the drug survival, or what we call nowadays the retention rate for the medication. And this is very important when you prescribe the medication for the patient, and also if you think about the economics, the health economics. The drug which high survival rate, which more retention rate, you should prescribe it. Now, when they evaluated the response, they used the EULAR good response and the HAC response, zero swollen and tender joint, and CDI. And why they used CDI? Because we know if you are using DAS28, ESR, or CRB, CRB might be affected by IL-6 blockers, and you might have challenges that this due to the medication. So they eliminate the effect of the drug by using the C dye. Now this is, as we say, the study endpoints. The response was measured by using the good Euler response, the hack improvement more than 0.2, swollen or tender joints, and the C dye to be less than 2.8. As all you know, this is the remission cut points. So now this is the demographics, which is not, important to us. Now let us talk about the things that we should pay attention, which is the result when you are prescribing the medication. Now, if we talk about the first line management, first biologics, which one would you choose? If you see here, the patient who's starting non-anti-TNF versus TNF agents as first biological therapy had higher proportion of remaining on the drug. That means higher proportion of patients achieving the endpoint of this study. Look here to the 1 year Euler good response and hack. In patients receive a TNF, it's almost a quarter of them, they achieve the endpoint result. For rituximab, 28% they achieved 1 year good response, and 37% they achieved the hack improvement. For abatacept, it's almost 1/3 of patients. For tocilizumab, 50% of patients, half of them, they achieved 1 year good response, and 43% they achieved the hack improvement. So in this real life data, they showed that tocilizumab, it's the highest agent for achievement of the end point of result of the study as compared with anti-TNF. Now after switching the patient, if you started your patient on anti-TNF and then you switch your patient to different agents, either anti-TNF or rituximab, tocilizumab, abatacept, and then again they evaluate it. Of course, the anti-TNF is low, and we know that from different RCTs. Roaming or recycling anti-TNF is associated with lower response. If you look to the RCTs, randomized controlled trial, the response to the second anti-TNF is almost 50%. To third anti-TNF, it's almost 1/3, 30%. So recycling anti-TNF was shown in different RCTs. But what's about the others? We don't have enough data about the others. And they showed here clearly that if you wanted to choose the second agent, probably tocilizumab, it's the highest to be to achieve the end result points, the Euler good response and hack. And this is very clearly demonstrated in this study. Rituximab, it's also better than abatacept. So abatacept is almost similar to the second anti-TNF when you switch your patient from failure of first anti-TNF. Now this is very interesting and very important slide. We always think about the drug survival rate. When you start your patient on anti-TNF, how many of them they will continue? After 3 months, they found there was different agents, no significant difference. So probably 3 months, it's very early to judge. However, most of studies, they report their outcome at 3 months. But look after 1 year. Now, out of 92, 65, they continue anti-TNF. So the drop is around one third of patients, 30%, they dropped anti-TNF. They stopped anti-TNF. So the drug survival rate is low in anti-TNF as compared to tocilizumab, which almost 18%, they stopped the medication. Out of 93, 76, they continued the tocilizumab. If we look to the abatacept, out of 94, 76, which almost representing 19%, they continue the medication. Now, rituximab is different. And if you ask me why it's different, because even those people who report this study, they comment that there are a difficulty about rituximab. It's given IV, sometimes it's interrupted. The reason is not clear why it's interrupted, and then restarted. Whether it's interrupted due to the efficacy side effect, it's not clear. So it's very clear that tocilizumab, the drug survival rate at 1 year, it's higher than anti-TNF. Now, if you look to the endpoints, all the clinical endpoints were higher in patients who received tocilizumab as compared to the anti-TNF. Look to the ULR good response. It's achieved in 50% of tocilizumab patients as compared to quarter, 25% of anti-TNF. And also the CDI, it's achieved in almost 14% as compared to almost quarter of patients with tocilizumab. So if you look to the drug survival rate, rituximab, it's the highest one, but again, probably because of the selectivity, we select our patient, they have to be seropositive, so might play a role. But when we compare the anti-TNF to the others, now at 1 year, the first 2 years, tocilizumab, it's higher than the anti-TNF and abatacept. After 2 years, abatacept is almost matching anti-TNF. And tocilizumab still, it's higher than the anti-TNF and abatacept as the overall drug survival rate. When we look to the discontinuation, most of biologics, we know our patients discontinue biological agents because of lack of efficacy. It's rarely discontinued due to the side effects. And again, tocilizumab, it's much less than anti-TNF to be discontinued due to lack of efficacy and treatment of rheumatoid arthritis over 5 years. When we look to the other group of patients, those who failed first anti-TNF, what did you do for them? If you start them on other anti-TNF, further starting them on different mechanism of action. And I would concern over 1 year, which is more important because the difference is more significant at 1 year. If you look to the response rate, the ULR good response achieved in the second anti-TNF in around 11.6% as compared to 34% in tocilizumab group. And the anti-TNF is almost similar to abatacept, although abatacept is numerically higher than the second anti-TNF. But it was very significant statistically with all the end result points with tocilizumab drug. Now again, when we look to the second agents, the drug survival rate. When we look to the anti-TNF, the second anti-TNF, it's the lowest agent to be survived, to be continued used as compared to the others, then abatacept, then tocilizumab, and finally rituximab, with some concern about the selectivity bias. So tocilizumab is associated with higher drug survival rate as a second biological agent. And again, when we look to discontinuation due to the lack of efficacy, much less patient was discontinued tocilizumab due to the lack of efficacy over 5 years. So in conclusion, this is a real-life data over a large number of patients, and it showed that patients, when you wanted to start the medication, those who started on non-anti-TNF doing much better as compared to anti-TNF as first biological demand. And after switching from the first anti-TNF, rituximab and tocilizumab, but not abatacept, were constantly associated with significant better drug survival and response. And the treatment outcomes among the RA patients in clinical real life was superior in form of effectiveness over non-anti-TNF biological demands, in particularly tocilizumab and rituximab as compared with anti-TNF. And this means we could use tocilizumab as first line as well as the second line with superiority of real-life data as compared with the other biological agents. And thank you very much. If there is any questions, I'm happy to answer before leaving. Thank you very much.